Dear Chairman, dear Co-Chairman, thank you so much for inviting me and for organizing this fantastic meeting. And thanks for everybody for attending this last day, but as Professor Shahab said, the best day, and for being here with us. My patient was in the 2008. He's a very famous Egyptian performer, a dancer, and a trainer of dance troupes. He was in several movies, and at that time he was born in 1930. He was 78 years old, and at that time he had dance studios in Buenos Aires, in London, and Paris. And whenever he went, he got up to show the young ladies how to mix between the salsa and the Oriental music. He got angina. He had a stress test by his physician, which was strongly positive, and he came for a diagnostic angio, which showed focal mid and distal LED disease. The bypass was declined by the patient as it would end his lifestyle, and we decided to implant drug-eluting stents. Please remember that at that time, this was before the Syntax trial came out. We had the data from Cypher. You remember the zero restenosis trial? We were stenting everybody. In the Syntax trial, some patients got up to 14 stents. So please don't judge me as an over-stenter, because those were my crazy stenting years. This was, this is an old synangio, but you'll have to take my word for it. He had relatively diffuse distal disease of the LAD, and in the distal third of the LAD, there were significant stenosis, and also just before the diagonal. I'm trying to show you as many, but anyway, there's a lesion here, here, and up there. Anyway, we did not have FFR at the time, and I was working from his right leg, 6 French. We wired his LAD, and I decided to stent the distal lesion first. It's very near the apex, but again, those were our big days of belief of drug-eluting stents. I would never stent that distally nowadays. This was post-stent. Because it was a 2.25, I decided to post-dilate it with a 2.5 balloon. Took the balloon in, shorter than the stent, and inflated to 18 atmosphere, an NC balloon, and then this failed to deflate. It just would not deflate anyway. And after you fail distal balloon, after the balloon fails to deflate, you have several options. One of the options is to try and perforate the balloon. One of the options is to try and rupture the balloon. You can perforate the balloon by a wire. You can take the hard end of a wire and reach it and perforate it. You can perforate or rupture the balloon by connecting it to, by inflating to very high pressure, if it's still getting, or even connecting it to a power inflator, or by pulling. Anyway, in our attempts to perforate the balloon, we did rupture it, and it ruptured the LAD with it. It was a distal rupture, just proximal to the stent, with free flow of blood and contrast into the pericardium. As my two colleagues, the two partners in crime who just showed you ruptures, exactly like them, I just put a proximal stent in the proximal balloon in the LAD and occluded the flow and asked for a Symbiot Stent Graft, which we had at the time. And the nurse came back and she said that the one we had expired, which I don't mind. I don't mind putting an expired Symbiot stent, but they had actually gave it back to the distributor, and we're waiting for them to bring, I chose the single day in which there was no stent graft in the cath lab. At that time, I was a proctor for Boston Scientific in magic wall stents and in a new device called a Symbiot, which I'll show you in a minute. You can see here the 2 dots, and this is the 31 millimeter Symbiot Stent Graft. Probably some of you have not even heard of it, but those old enough will probably have heard of it. But I was a proctor, and I had several on shelf. The smallest one was for a 4 millimeter vein graft, and the length was 31 millimeters. At that time, Magdi El-Khadim, my colleague, who Wael knows well, moved into the room and stuck a sheath in the patient's left leg and put an 8 French, because that works in an 8 French system. We did not know that we had probably performed the world's first ever ping pong. We didn't know it was called ping pong. It just seemed like a reasonable thing to do to us. And many years later, we read about the ping pong and, you know. But we basically, what we did is we put an 8 French cast guide from the other leg into the aorta, and then, you know, got very near the ostium, disengaged the 6 French guide, wired from the 8 French, which already had the Symbiot system in it, and reached the edge of the stent. And here you see the Symbiot, and I'll show you how it deploys. The Symbiot stent is a stent graft. It's a self-deploying stent. It's extremely low profile. It will track anywhere, much better tracking than a UMED stent graft. You select a stent length, which is longer than the lesion length. They are designed for vein grafts, so the smallest one is 4 millimeters. Our artery was 2.25 at this area, but it just gets longer. I mean, nothing happens. It just gets a little bit longer. You put it distally. The initial idea was to put it distal in the vein graft in a healthy segment, start deploying, so it opens up, and the stent graft would stop the gunge and the debris and the thrombi in the vein graft from going distally. So it opens distally, and then, it opens distally, and then you, all the friable material is trapped behind it, and then you, of course, you post-dilate it to optimize the size. It was never designed to use in a perforation, but because that was all what we had, and I had used them in vein grafts, and a year later, their randomized trial came negative, and Boston Scientific took them off the market. But at that time, I was lucky to have it, so I deployed it. And this is the stent graft immediately sealed the perforation, even before I post-dilated it. I was lucky because that area did not have any major diagonals, which we would have lost. The patient, all through, we had echo being done. We did not get any significant amount of pericardial effusion. We post-dilated the stent graft by a big balloon to make sure it's opposing. It was not a drug-eluting device. And then we had the proximal stenosis, which was just before the diagonal. So we stented that by another Taxa stents. Those were the early days of drug-eluting stents, and everybody was happy to put. And this was our final angiographic outcome. When we had an apical balloon inflated and not deflating, they called the cardiac surgeon, but I knew that this was just a formality because there was even no place for a graft. The cardiac surgeon would come and would probably just remove the thing. And I was thinking, would it be safer just to leave the patient to develop an apical infarction or to actually send him to surgery with all the anticoagulation? But anyway, fortunately, the cardiac surgeon came and watched from behind the glass with some other colleagues, and we got a good result. The patient had mild chest pain during the procedure. He had no CK or troponin rise post-PCI and no ECG changes. I became very friendly with this patient because I like art, and I was invited to many of the events that he organized, and I got many videos of him even as he approached the age of 85 and 86, dancing. He remained totally asymptomatic till he died of natural causes. I actually suspect it was COVID-related, but anyway, he died at the age of 90 in July 10, 2020. He did not like pills, so he was kept only on Plavix, aspirin, and a statin during all that period, and he never symptomatized again. He never got chest pain again. And my conclusion is that we present a case which has many firsts. It has never been presented in another meeting, and it still gives me a lot of chest pain to remember that day in the cath lab, in which we used a successful treatment of, can I just get the last slide just to read it, please? Anyway, I'll say it. We present a case which had some firsts. One of the firsts was using a device which we believe has never been used before in treating a perforation, which is designed for vein grafts, a size 431. With us, we managed to put in a smaller artery so that it would have been longer. We managed to complete the procedure with Texas stents with good angiographic and clinical outcome for all those years. We did what we didn't know it was called ping pong technique, but we did that anyway, putting another guiding catheter and playing with the two guiding catheters while a balloon was inflated, so that to the extent that we did not need to do any pericardiocentesis. And it just shows that what we all in this room have to face every now and then, which is totally unexpected complications. And when you have the, you're awake and you know the equipment that you have, and you can improvise, and sometimes you can solve problems pretty long term. And I thank you very much.